We welcome to the stage Dr. Ander Cohen. Anders really is the international expert on the epidemiology of venous thromboembolism. He's done a huge amount of work and continues to do so. He's quite a challenging speaker and he'll have you thinking, I'm sure. Anders, over to you.
Good morning. Dear chairpersons, Beverly, thank you for setting up so much of the work that we enjoy in today. David, for your presentation, and particularly AJ for setting up the talk in such an erudite way. I work here, and so I just thought I'd show you a nice picture. And my job is to sort of fire you up before the call to arms. I'm sort of like the trumpet or the bugle player. So I'm going to do a bit of bugling, and I'm grateful to Beverly and David for letting me bugle about something that I've been banging on about for 20 years. Actually 20 years when I started sitting down with a colleague of AJ and mine, Bob Edmondson, and we spent many a cold winter looking at 21,000 autopsies at King's College. I'm going to talk a bit about drugs, so I'll just show you some disclosures of various types. I may even talk off-label. So what is the burden? It's two things. It's morbidity, which I'm going to deal with first, and it's mortality, which I'm going to deal with second. Some years ago, we worked on a incidence-based modified model where we modelled thrombosis throughout the EU and North America. And we published these two pieces of data, and we made an estimate of the morbidity and mortality in the EU and United States, working with John Haidt from the Mayo Clinic. And we came up with figures that people weren't entirely comfortable with. They thought that's too many. You know, you can't have 500,000 deaths related to venous thrombosis in the EU. We're only losing 5 million people, 6 million people a year. You can't have 500,000. And of course, this data was then taken here and compared with similar figures that looked maybe 60,000 deaths in the UK, maybe 25,000 deaths we could do something about. So we published this data, but because we wanted to alert people that this was a much more common cause of death than people suspected. And at the same time, we looked at other causes of death in the EU, and we published this data. And this sort of theme was taken up fairly broadly, that you might be wearing a little pink badge for breast cancer or a blue badge, red badge for HIV/AIDS. But if you wore a sort of purpley badge for blood clots, people would say you are a clot. You know, they're not really interested in blood clots. And that's one of the problems we had. But we also estimated the cost back in, whenever that was, 2007. And we thought that in the EU it's about 3 billion. But more importantly, we looked at the extent of the cost that was in the community and the extent of the cost that was related to hospitalisation. And about 1/3 is related to community acquired, and about 2/3 is hospital acquired. Now, when we talk about hospital acquired, we're not just talking about what goes in hospital. It means they've been in hospital. They may now be in the community, but if they've been in the community for 3 months or so, we still define that as hospital acquired. So there's a lot we can do in the hospitals. Now I'm going to start, as I usually do, with my conclusions, and then I'm going to talk a little bit about prevention, treatment and morbidity and mortality, and then I'm going to conclude, but I've got a quiz for you. what's the commonest outcome following VTE? Well, most people say, oh, it's probably post-thrombotic syndrome. About 40, 50% get heavy legs or heavy arms or something like that. And then the other half of the audience will say, no, no, it's recurrences. 40% get recurrences. That's pretty fair, isn't it? They're the commonest causes, commonest complications. Well, they're not. They're not. That's mortality, that's death, over 50% at 8 years. That's recurrences, that's ulcers, 10%. Probably if you put PTS in general, it's up around 45%. But the commonest outcome is dying. And that's because, unlike the patients that are here today, many patients suffer from heart failure, respiratory failure, cancer, and other conditions. And we're just not good at recognising thrombosis. So here are my conclusions. I think the global burden's underestimated. I think we need to look at the morbidity and mortality, that all-cause mortality is the commonest outcome following both DVT and PE. The best way to predict thrombosis is to predict no thrombosis. To predict no thrombosis really is to give thromboprophylaxis, effective anticoagulant thromboprophylaxis, the only thromboprophylaxis that reduces total mortality, as AJ showed earlier from some of the work from his father. It reduced total mortality and fatal pulmonary embolism mortality. You don't get that with any other therapies. I think the politicians, both professional and medical politicians, hold the key to this, and I'll explain why. And I want to talk to you about the new anticoagulants because I think they're a significant advance. I think that they will lead to longer therapy, and that's what we need. Most of the work I'm presenting today comes from a group called VEG, as in meat and to veg, and we're the Venous Thrombosis Epidemiology Group. We used to work more at King's College. We're now working more at Guy's and St Thomas's in Professor Hunt's unit. And we're also based in Frankfurt at the Institute of Pharmacoepidemiology. Now, this is what we did in the last 5.5 years. We joined the community practice database, we joined it to the hospital episode statistics, and then we joined it to the Office of National Statistics. So we're able to follow people from birth to the general practitioner, out of the hospital, back into the hospital, dying in hospital, dying at home. We know what drugs they've got, we know what symptoms they've got. We've got a cohort study, 35,000 patients. We're about to go to 50,000 patients because we've just added 2012 and 13, and it's getting bigger. We're about 15 times the size of the biggest cohort in the world. And we've got a problem. We've got a problem because there are politicians that are stopping us joining these databases because they're worried about patient confidentiality. This is highly encrypted data. And we understand that, that the civil libertarians want everything locked up, but this is the key to ongoing health. So we need to keep this information flowing. You see, what we get is very good estimates. This is our paper of venous thrombosis. Very similar to what the Canadians got, but they don't have symptoms and signs. The Australians mainly looked at general practice, so that's why it's low. French, Norwegians are similar. USA, they don't have general practice data, they have hospital data, and that's hospital data in Asia where they don't really investigate, so there's huge diagnostic bias. But it's more than just getting the incidence rates because these are new thromboses. Sometimes you look at results and you see more than just the incidence. When they describe the epidemiology, they describe the attack rates. Now, attack rates are different. Attack rates are new plus recurrences. So suddenly you go from sort of 146 up to 148 plus 95. You get round about 250 per 100,000 because you're looking at recurrences. Because there's with time. And so you have to be careful looking at these figures. But what you get is something a bit special, because look at the incidence rate here and look at those confidence intervals. 131 with confidence intervals of 129 to 133. And that's because the UK have a fantastic system of collecting data. And we can be really, really accurate in predicting and stating what the incidence is. And we need this information. We need it to keep going. And we have to appeal to the politicians to do this. AJ? They like changing everything. We know that. They've changed the NHS so many times, but they need to change it again with respect to thrombosis. They state the obvious. That's good. We like people to state the obvious. We need politicians to allow us to keep going with our work. We don't need people talking about triangulation or jigsaw methods of identifying people with 5 broken noses. This is important for all the community. Prevention. Well, this is one of my favourite slides, and this is the one I've been banging on for ages, because these are the deaths in the VITAE study. So the first thing you'll notice is 1/3 of the patients just die suddenly. No diagnosis, die at home, die within a couple of hours of arriving in the accident emergency department. And that's what the autopsy studies show in the UK and in the United States and elsewhere. But 60%, we clever doctors and nurses are not making the diagnosis. We're treating them for heart failure, respiratory failure, infections, arrhythmias. And I'm going to tell you why we're doing that and why we're making that mistake. But once you get on treatment, that only contributes to 7% of the mortality. So if you can get onto treatment, the majority of patients have a very low death rate. These are the treatments we should be using. These are the new oral anticoagulants. They're just as good at treating recurrences and death from pulmonary embolism as warfarin, heparin, other vitamin K antagonists. They're just as good. I might just use my finger. Oh, thank you. But they're safer. They're safer. And yet we're told by our politicians that our medical politicians, the people in NICE, we're told by them we can't use them unless the patient's INR is up or down, or they've got an allergy to warfarin or something like that. That's ridiculous. These drugs are saving lives in patients with atrial fibrillation. There's a 10% reduction in mortality in atrial fibrillation. There's a huge reduction in major bleeding. I'm not talking about any old bleeding. I'm talking about bleeding into the brain, retroperitoneal bleeding. What are our politicians, our medical politicians, what are our GPs all nodding their heads at and saying our hospital doctors, only going to give them to those patients with high INRs or low INRs? The studies didn't show that. The studies showed they worked very well in all patients in VTE and all patients getting factor 10 inhibitors for atrial fibrillation. So once again, we've got to deal with the medical politicians. They're as effective, but there's less bleeding. There's less bleeding in the brain. Why aren't we using them? Why are we still using warfarin and heparin? Because we've been beaten by the system. We're told we must hold the purse strings because we haven't got the guts to do what's right for our patients because we're too worried about spending money in our precious NHS. Is that radical enough? So there are those politicians again. We've got to speak to them. They need to hear, and that's what Beverley's institution does. Of course, we know if we're going to that it increases with age. We've shown it increases with age. But that is first VTE. What we didn't realise until recently was the recurrences, the incidence rates of recurrences don't increase with age. Well, we thought they did because we used to be able to look at this part of the curve. These are 20, 30-year-olds here. These are the young people. This is what we showed in our latest paper. And we couldn't have shown that without the 35,000 patients we have in our study. Of course the young people get more recurrences because they've got healthier vessels. They must have some powerful pro-thrombotic state to get their first VTE. So this is what we're finding out, and we need to find out more. Post-thrombotic syndrome. We know how common it is, but this is what we found out. People study post-thrombotic syndrome after DVT. Look, there's after DVT. What's the blue line? After PE. Lots of patients get post-thrombotic syndrome after PE. Why? Because at least 80% of them have had a DVT, and at least half of those haven't been diagnosed. And we can show that here because we've got so many blooming patients in the UK that have interesting anonymised data. CTEPH, once again, at least 5%. But look at that. PE patients, we know they get chronic thromboembolic pulmonary hypertension, but they're the DVT patients without a diagnosis of PE because 50% of DVT patients have had PEs. And here's the rub. Look at that. Look at the TTRs. Greater than 60, 40 to 60, which you're lucky if you're in that 40 to 60 range in the NHS or in the United States. Most of them are around 40. The average TTR in an acute VTE is 38% in the United States, and it's not a lot better in the UK. And look, you get a quarter of the chance of developing chronic thromboembolic pulmonary hypertension if you've got a decent TTR. The problem is we can't do it. We're no good at it. Why are we giving warfarin? We should be giving the NOACs, at least seeing whether they work. It's hypothetical, but it's likely if you get the right patients, they'll be better anticoagulated. Mortality, favourite subject. Once again, I'll come back to this slide. We can't diagnose it. We can't stop the acute, sudden, unexpected deaths. We have to prevent it. We need a simple approach. And you know, in these days, the politicians need to talk about everyone involved in these conditions and get things straight. Alive or dead. We're not suspicious enough. We don't think about it enough. These are clever doctors. They're thrombosis experts. They're just looking at the ones with a clinical suspicion. Goldhaber from Boston, Harvard, all these other ones, Europe, United States. 1/3 of the time they suspected it. So that's what went on the death certificate. So 2/3 of the time we're putting the wrong thing on the death certificate. And look, 4% of all deaths, 3%, 4%, 9%. But these are in the patients where they had a chance to suspect something. There's none of the sudden deaths, you can't suspect it. So these figures are interesting. Mortality is something that is very much a part of venous thrombosis. And this is the reason why. This is the reason why we get it wrong. We get it wrong because there aren't many thrombosis people. You see, if you go to a cardiologist, they'll call it cardiac rupture. If you go to a general physician, they'll call it heart failure, because that's what they see. Sometimes the cardiologists call it arrhythmia. Surgeons call it syncope because they don't know what syncope is and they're just happy calling it something. Physicians, acidosis, arrhythmias, often, only haematologists get it right. Other physicians, other doctors, no idea. So my point is that if we're not thinking about it, if we're not making the diagnosis, we can't do anything about this. So we need to make people more aware, and that's what Beverly and Lifeblood do, and we try and do, and we need you to do, to bring it to the attention. 5 studies, 981 autopsies from Ueland in 64, 10% had fatal PE. 252 from Greece, 9% had PE deaths. 1,000 autopsies from India, from another KCAR in 2008, 16% PE, 12% PE deaths. Young population in this Indian group, around 50. Our work that we published, 6,800 autopsies, PE deaths in 5.2% of the adult cases. Unless you believe that people dying in hospital are dying from something different than people dying at home, then somewhere between 5 and 15% of people are dying from PE, and we're not diagnosing it. We've got a big job to do. Thank you, Simon. We can't just ignore this, and that's what's happening. And look again at death. This is death. This is from our work. TTR greater than 60, half as likely to die as the TTR under 40. Epiphenomenon? Possibly. But it still makes you think, why is there this association? And why are we giving drugs that make people bleed more? It's down to the politicians again. We need to stop rationing. We need to start allowing people to do research and giving them the best possible therapies. Conclusions, just as before, VTE is underestimated. We need to address all the morbidity and mortality. Mortality is the commonest outcome. It's not what we're taught, but it is the truth. The best way to predict is to prevent. The politicians, the medical politicians, the people in NICE and the people across the road need to do something about this. And I think the new oral anticoagulants or the direct oral anticoagulants have a very important role to play. Thank you very much for your attention.
Well, thank you very much. I'm just glad you weren't controversial. Any questions for Ander or to push it further? I mean, I've got a methodological question really about how you do that linkage across the primary care centre going into phase, because we've been struggling to actually make sure it is the same patient.
Yeah. You know, more recently you received what's called an NHS number. Well, that NHS number has always been there. It's just that you've received it recently.
Okay.
So whether you have something recorded in HES or CPRD or ONS, there is a unique patient identifier. The trick is to encrypt it, and I think we do a better job than the phone hackers and other people to encrypt data. It's very, very carefully done.
Well, I'd absolutely agree with you that kind of research is absolutely essential, particularly as people are staying in hospital such short periods of time now.
Yeah.
Yep. I think someone's going to get you a mic. Can you just tell us who you are?
Henry Watson. Ander, if 10% of the population are dying of pulmonary embolism, what percentage of that 10% do you think is preventable? And can you sort of talk me through your rationale for that?
We think about 60% is preventable. We think 40% might be agonal, that it may be related to an underlying cause like cancer, like end-stage heart failure. We think 60% has the potential to be prevented, and we think that you'd get a 2/3 reduction in death, because that's what has been shown in the studies. So we think about 40% of lives could be saved.